I'm pleased to be joined now by Dr. Vincent Chan from Ottawa, Canada. Vince is a newly minted professional cardiac surgeon. You've had extensive training, I know, but you've been out of your training program now for about a year. So you're going to give us some great advice. What advice would you have for trainees who want to really become expert in mitral valve surgery?
Well, it's interesting. There's such a long journey, I think, with this, and certainly, my rookie season, I think that it's important to sort of pick your patients well,
right,
and then also pick your team well. So, I think the team is very critical. So I've been very fortunate to train with Dr. Adams previously, and I took notes during my fellowship year. And certainly in the center where I'm at now, we have a preeminent expert in Dr. Misana, who is very instrumental in continuing the mentorship process. But we certainly lean heavily on our anesthesiologists to make sure we have good echo assessments, and then also our good nursing team to make sure that we can do these cases expeditiously.
And I would agree with you. But as you're walking, if some young cardiac surgeon came to you and said, Vince, I want to become an expert in mitral valve surgery, what would you tell them?
Well, I think that the important thing is to get comfortable with exposure to the mitral valve. So, the first bunch of cases you get, you're not going to get the asymptomatic MR patients, and nor do you want to have those patients. So, picking up call, and you're doing a lot of mitral endocarditis patients, ischemic MR. And then I think this just gives you more comfort in seeing the mitral valve, getting the exposure, so that when you do these, higher index cases, that you're more comfortable with it. So exposure is one, and then even trying to find patients where early on you want to have as much time, clamp time as you can for the mitral valve. So even trying to find patients where you don't have too many grafts, any concomitant aortic procedure or tricuspid procedure, it's helpful. And certainly a lot of teaching I had with Dr. Adams was also to take your time and with good myocardial protection and with good retrograde protection. You can really keep the clamp on for a while and enjoy yourself so that you're not stressed about time.
Vince, you now are heading in Ottawa, heading up a program there in this, and so is that intimidating to come out of training and sort of be thrust into this leadership position?
It is, and I've had a lot of opportunity support from my group back home to be able to develop this expertise, and I think that's the major thing. To come in as a new surgeon is very challenging, but certainly the senior surgeons in my group are very supportive of this. It's funny though, I come back home to Ottawa in July when I started my practice, and my chief had left for France for a couple of months, and then I just came back as this surgeon that trained with this preeminent valve expert in Dr. Adams. So I was getting all these referrals for the first couple of months from these really sick patients, and I remember talking to a couple of my partners back home, and it's intimidating to get these double valve endocarditis patients in the first couple of months. So it was nice to have certainly a supportive surgical group to talk about these patients. But now I think it's just a lot of fun. You see the valve a lot, and certainly develop your own sort of style and skill set with it. I think for developing a program or enriching a program, the one fortunate thing that I've been able to do is to use our structure back home, having had some epidemiology training, and at least bring something back to my program. Being a young surgeon, I can't say I'm going to walk in there and be the best thing.
3,000 cases.
Right, exactly. And nor is it appropriate to say that. But, at least if I have some skill set in epidemiology, we're able to develop outcomes.
You look at outcomes data, which is very important.
And at least this way, contribute to the program and the understanding of mitral valve.
Let me ask you about the conclave in general. Obviously you trained with David and you had great exposure to fabulous surgery and team and all that sort of approach, but this is a really dynamic meeting, isn't it, from your standpoint?
The one thing I like about it is that there's a nice balance of lectures and primary research. So I think primary research, it's certainly very important, certainly very interesting, but to have dedicated lectures on how to handle certain valve lesions, certain controversial topics of guidelines, etc., I think that's very important, and it's, we're all learning, so it's nice to see that. And, in your regular practice, it's not all mitral valve disease, you're going to be doing coronary surgery and other valve surgery, so it's nice to sort of have a few days to just focus on one valve and then think about how you want to develop your practice and the program.
That's great. Final question. So you're freshly minted. You're over your rookie season.
Sure.
Where do you, if you look 5 to 10 years down the road, where are we going to be with degenerative mitral valve surgery or procedures?
Certainly minimally invasive is certainly where I think cardiologists, patients, and surgeons are moving. The only concern that I have is, when you're adopting these technologies too early or in programs where you have lower volume, then you have suboptimal results.
Right.
And then that could actually be an entry point for percutaneous technologies, which give probably medium quality results to say, okay, well now we have a better therapy than surgery.
Right.
So, I think that with degenerative valve disease, where the stakes are so high, that it's very important that we still focus on quality, and certainly to try to advance and try to make smaller incisions. I think is very important for the patient.
But you're really talking about having excellent outcomes. Everything stems from that.
I think so, and certainly, even looking at the analogy with PCI and CABG, if you want to maintain your role in patient care, you have to have good outcomes for the patient, and I think that's certainly one thing that I learned from all my mentors. So.
Good. Listen, thanks very much. Congratulations. You survived your rookie.
I know, I survived the fellowship too, which is pretty challenging.
Which is really challenging. I know. Thank you very much.
Well, thanks for your
Appreciate
time.
it. Thanks. Good.